Hello, good afternoon. Good afternoon. So welcome to the second of the OSCA Stop Pressure Ulcer session today. Sorry. So my name is Valerie Dowley. I'm an independent tissue viability nurse and I work with OSCA.
And I'm Anita. I am the clinical support nurse for OSCA.
And as I said, welcome. Today is Stop Pressure Ulcer Day nationally and internationally. So there's lots and lots of educational events and events going on within hospitals and communities promoting awareness of pressure ulcers and how pressure ulcer management is everybody's business. So we're just going to give you a brief 30-minute sort of refresh on pressure ulcer within this sort of asking model. And if you have any questions at all, please feel free to put them into the chat or into the question and answer section, and we'll try and get back to you at the end. And if not, if you want to hang around and ask us a question afterwards, then feel free to do that. So as a refresh, a pressure ulcer is a localized area of skin damage caused when tissue is compressed between the bone and a support surface. And if it's compressed for a long enough time due to sort of sustained pressure, then the blood vessels start to die off and the tissue starts to accumulate chemicals and waste. So it's really as a result of sustained pressure. It can manifest itself as intact skin, or it can be something like a shallow ulcer or a deep ulcer. There are now 7 categories. Since 2018, we've adapted some additional categories. So you have your normal category 1, 2, 3, 4, unstageable, and we now have a category which is called deep tissue injury, which is where we've recognized that there's a point of time between when deep tissue damage happens and when that damage dies off and becomes necrotic. So there's a period of time between that where the tissue is still struggling to survive and hasn't quite died off yet, and that is where it manifests itself like a bruised area, purple bruised looking area on the body. So it can look like a bruise, can look like somebody's fallen and sort of hit their bottom, but obviously they would have had a period of sustained pressure and immobility as well. So that's deep tissue injury, or you might hear it called DTI. And then the 7th category is around pressure damage that is caused through use of medical devices. So any devices that we as healthcare practitioners give to our patients or apply to our patients or use on our patients as part of their therapeutical journey potentially could cause some pressure if it gets trapped between the support surface and the skin. Isn't that right? Okay. So if we just do a quick refresh on the asking model, asking is a framework where nationally we're trying to look at standardizing both the language and the education and the framework around pressure ulcer management and prevention, because it's really important that we all really sing off the same hymn sheet, to be honest with you, because there has been so much different use of terminology. So the asking framework is around looking at assessment, looking at skin inspection, support surface, keeping people moving, incontinence, nutrition and hydration, and giving information. So that's a framework around which all of the principles of managing pressure ulcers fits into, and helps us to really care plan all these aspects into our individualized patient care plan. So if we look at assessing risk initially, so risk assessment is done because it is vitally important for us to detect early on individuals who are at risk of developing pressure ulcers. So we need to do that. So we use risk assessment tools which ideally need to be validated, repeatable and reliable. So we need to make sure that we're using a good risk assessment tool. But alongside that, we need to make sure that we use the risk assessment tool as a tool, because that's what it's called. So it's important that we don't just rely on the tick box and the figure that comes out of using a risk assessment, and that we look at it alongside that holistic assessment and our clinical judgment. So we have to put an umbrella over that risk assessment tool, so that, because there has been incidences, and you've probably seen them yourself, where a risk assessment tool might come in showing somebody at low risk, but actually when you look at them holistically, they are at much higher risk, or they're heading to a higher risk category. So, and certainly in a court of law, using just a risk assessment tool and saying that you based your decisions just on the score that you got from a risk assessment tool is no longer good enough, really. It also, a risk assessment tool and our holistic and clinical judgment allows us to plan a individualized care for that patient, and it helps us to incorporate the sort of key resources that we have to help us prevent pressure ulcers. So we need to also remember with a risk assessment is that we need to revisit the risk assessment when patient's condition changes. And even if that condition changes, is it only for a short period of time? Sometimes that short period of time can be an incredibly dangerous period for the patient. So for example, you might have an elderly patient under your care who generally gets up and moves around, even if it's slowly or with prompting, but they might sort of get a flu over the winter, they might get some diarrhea or vomiting, and they take to their bed for 2 and 3 days. And although you know that, you know, they've done it before and they come out of it, in that 2 or 3 days, even in that 24-hour period, their risk factors just shoot up through the roof. So whereas previously they were mobile, now that they're feeling unwell, they become less mobile and they're less independent movement, and therefore the risk increases. So you may have to move some resources to support them for that period of time. And then the other good thing about risk assessment and that continual revisiting of the risk assessment is that it helps you to make sure the right equipment and resources get to the right people, but it also helps you to free up some, especially some of the high-end equipment resources, because obviously if somebody has deteriorated but has then recovered afterwards because it was a temporary thing, then if they're reassessed as not being at such high risk, then things like dynamic mattresses could be moved off the patient and they could be put back onto a static surface, depending. So it helps you to keep your resources moving and keep your equipment. So who is at risk of developing pressure ulcers? Well, everybody is really, and how everybody is based on their mobility. So mobility itself is the first and the biggest factor that places people at risk of developing pressure ulcers. So when we're independently mobile and moving around, we relieve pressure regularly, our circulation's in good condition, and our skin remains healthy. But obviously, the more immobile we become, whether it's just reduced mobility that might need a bit of prompting, or it might need a bit of support, or whether it's being totally immobile. And that is alongside other things such as long-term conditions such as diabetes, patients with spinal cord injuries, perhaps, the elderly or the young, patients with reduced sensation who can't feel where pressure builds up. And that's particularly important in patients who maybe have cognitive impairment or maybe brain degenerative disorders, because often they lose the perception of what is causing that pain. So they might feel the pain, like you and I, when we're sitting here, and we'd feel when pain is building up and we'd get up and move around. But people with cognitive and brain degenerative disorders, they still feel the pain, but actually they don't remember what that pain means by the time it gets to their head and is translated into a message. So we need to be really careful about those patients. And pressure ulcers can occur, as I said, also under medical devices. So we need to be really thinking about the stuff we're using on our patients. It might be absolutely necessary to support them. Things like oxygen masks, catheters, tubing, pegs, even the straps we use on catheter bags to hold them, splints, plaster of Paris, Even things like compression stockings or even compression bandages for that matter, and even little things like TED stockings, which we kind of take for granted, don't we? Because elderly patients often get put on TED stockings when they go into hospital, but they're moved out so quickly they haven't even had them taken off by the time sometimes they get home or they get to you. And they're the hidden things that we need to be looking at. So we need to be reminding carers, or we need to be reminding family members to check those areas regularly. So I'm going to hand over to Anita, who's going to talk to you about support surfaces and, okay.
So actually, we'll go.
Oh, I know we
Okay,
haven't
we'll go
actually, sorry,
right,
we forgot one. So let's start. So when looking at risk, we also need to look at keep our eye on the skin, and doing a comprehensive skin assessment when somebody's admitted to your care is really important. So we need to visualize the skin. If we can't visualize the skin, we certainly need to be asking the most relevant questions, in whether there's areas that they feel pain or bruising or bleeding. It's not just good enough to say, oh, well, the patient refused for me to see their skin, and you document that. You need to be able to show that you've done everything possible as a responsible clinician in asking them the relevant questions, so that you can walk away and say, well, as far as I can make out, there is absolutely nothing. And often actually even asking those questions, doesn't it? If you ask, so, you know, have you got a sore spot? Oh yeah, well, my bottom's a bit sore. They might then let you see that area.
Yeah.
And remembering that when we're assessing light or white skin tone, we need to remember to use that blanching test. So blanching is where you have an area of redness on the skin, and if you press it with your finger, then if the blood vessels are open and moving, then it'll blanch white. And that means that the blood vessels are viable, they've not died off yet. But if you have an area of redness on your skin and you put some pressure on with your finger and it stays red, that is a category 1 pressure sore, a pressure ulcer, and we need to be really proactive at that stage to make sure that we're offloading and moving and repositioning. Now, with darker skin tones, we can't use the blanching test. So we need to use our other senses. So we need to think about what we can see. So visually, the area might be more swollen and edematous, because when things get inflamed, it gets swollen. There might be a discoloration. It might look a bit more bruised or violet or purple. We need to use our touch sensation. So the area of the skin might be warmer than the surrounding skin, because again, with inflamed skin, it's hotter and warmer, and it may be colder if the blood vessels have actually died off. It might be colder. And we need to ask, we need to verbalize, because I could ask you, if you were in a room with me, if any of you have developed pressure damage yourself, and most of you usually say no, but actually I'd ask you, the question is whether you've ever bought a pair of shoes and rubbed the back of your heel down. It's very similar to a category 1 or 2 pressure damage. And that's very, very painful. So the research is absolute that pain is a real high predictor of somebody's risk of developing pressure damage or their risk of deteriorating pressure damage. So ask them about pain. And if they aren't able to verbalize their pain, then look for signs that they are agitated or that something has changed. So I used to have a patient who used to scratch his bottom a lot when he was under pressure and stuff like that. So sometimes they can verbalize it that way. And we need to think about those areas that are out of sight, out of mind. So we did talk about the medical devices and removing stockings and slippers and socks and splints. Sometimes we might need to think about using a mirror if it's difficult to get around the back of a heel, or if a patient maybe is obese and it's difficult to get around. So using a mirror, that can be wiped down. So for infection control purposes. Think of other areas we might think of, like the back of the ears if patients are wearing glasses, the elbows, the ankles, especially if they lie on the side, and especially if they have a preference for one side or another. And even around the rib cage or the spine column, especially if patients have lost weight and maybe they have a bit of spinal curvature in that. So sometimes we focus a little bit too much on heels and sacrum and bottom, when actually there's lots of other places we need to think about. So now I will hand over to Anita and let her talk to you about some support surfaces.
So let's have a look at the next S in the Afghan Care Bundle, which is obviously selection of support surfaces. So I thought it was just beneficial just to run through kind of the different types of support surfaces that are out there. And if we look at the very first kind of rung of the ladder, as it were, we have our standard pocket sprung or foam mattresses. Now, these are the sort of mattresses that we purchase ourselves, that we have at home, that we're using day in, day out, night in, night out. And they are suitable for people who are fit and well, able to move, but not necessarily suitable for our patients, essentially, because they certainly wouldn't be suitable for someone who wasn't able to move, or someone who has existing or has had pressure damage. So for the majority of you listening and watching today, I'm sure that isn't anything that you are using for your patients, but anybody who's out there in community may well see their patients on these surfaces before you then obviously assess them for needing something else. So when you do then kind of step your patient up, obviously depending on their risk assessment and your clinical judgment, you may well be stepping them up to that next rung of the ladder, which is the pressure redistribution high spec foam or viscoelastic mattresses. Now, these are generally high specification mattresses, and they are generally suitable for people who are deemed either at risk and potentially high risk if it's from a prevention point of view. I would very much check with manufacturer guidance as to what each manufacturer would suggest their mattresses are used for, because that will differ. But generally speaking, these type of products will be suitable, like I say, anyone who's deemed risk to potentially high risk prevention. And they will be able to move themselves. So we're not looking at these sort of products being for people who cannot reposition themselves at all. And certainly they wouldn't be suitable for people who've got existing pressure damage. For those sort of patients, you then might be stepping them up that a little bit further to the next step, which would be the reactive pressure redistributing either foam, static air, or potentially gel products. So these would be suitable for those patients who are deemed medium to high risk. They may have some ability to move, so they may be able to reposition themselves. It may be that they're dependent on being repositioned. And it may be that these sort of patients aren't able to tolerate a fully dynamic surface. So it's kind of like your next best option, essentially. So for patients that don't like the movement, a reactive pressure redistribution surface is normally really suitable. And then the last thing we would see is our patients who are high risk to very high risk with existing pressure damage. You're probably talking those deeper kind of pressure ulcers, so category 3s, 4s, unstageable DTI, etc. Having a active or dynamic mattress, you might also know them as airflow mattresses, air mattresses, but basically mattresses that have got a pump attached to them where there are air cells being inflated and deflated under the patient to relieve pressure. And as and when, obviously, one of those cells deflates, that will offload the area. But what you also need to be mindful of with these air mattresses is as and when they inflate, the pressure of those cells are a little bit higher initially to support the rest of the body as and when one of these cells or several of the cells are deflating. And they generally work on a cell cycle, so maybe 1 in 2, 1 in 3, 1 in 4, and they might have features that will help with skin microclimate, like low air loss, and different features within the mattress that will also help with that very high risk category. So they're the sort of support surfaces that you won't be using on absolutely every single patient that you have, but there may be that sort of small amount of patients that are deemed that high risk that you would want to be using them on. The key to any support surface is about having good levels of immersion and envelopment. And by immersion and envelopment, we mean your patient being able to sink into the surface, so that's the immersive quality, and then the ability for the mattress to come out, or the support surface to come up and around them and envelop them. And what we're trying to do with that is just to maximise the surface area or the body contact with the support surface so that we can redistribute the pressure over a larger area. And by doing that, we lower what we call the interface pressure. And the interface pressure is the pressure that builds up between the patient and the support surface. The reason we lower that pressure is because we can't do anything necessarily about the internal pressure going on. So we do know that the internal pressure at the bony prominence can be 3 to 5 times greater than that of the actual interface. So we can manipulate that part of it by using support surfaces in order to do so. So that leads us nicely onto the keeping moving part, because obviously support surfaces will help to a certain extent, but we also need to think about how often we're repositioning our patients. And if they are able to reposition themselves, how often are we encouraging them to do so? So it is indicated in the NICE guidance and by EPUAP that we should be repositioning our patients unless otherwise contraindicated. And that we need to be following an individualised schedule for that. So yes, we do have, I suppose, a historic rule of 2-hour kind of repositioning, but we need to think about what is right for our patients and what is best for them. So it may not be that 2 hours is suitable. It may be that we need to think about every 3 hours or every 4 hours, or even a little bit more often than every 2. So it really is individualised and tailored to your patients. We also need to think about that everybody's anatomy is different as well. So in the parts of the body that are maybe taking more of a load than another part might be different from patient to patient. So we need to think about how we can provide good offloading on those areas. So it may be that we need to think about, again, how often we're repositioning, but the type of positions that we're putting our patients into as well. So don't be afraid to use equipment in order to help repositioning. So profiling beds, for instance, can be really helpful for somebody who is maybe immobile and in bed. Along with the support surface, you can obviously tilt the head up, bring your knee break up, etc., and change position to just reduce the pressure. Reduce those peak pressures on the bony prominences. You also may want to think about that kind of tilting your resident, so sort of your patient anywhere sort of between 20-30 degrees is obviously recommended in order to obviously offload those areas where the pressure may be building up. If your patients are able to reposition themselves, then think about how often you can encourage them to do so. So you may want to encourage them kind of every 15 to 30 minutes to reposition themselves. And so again, that will be tailored to that individual patient, but it's also about thinking about how can you indicate to your patient that they need to change position. So can you think of any visual cues that they can have in order to know, well, every time the ad break comes on, I know to reposition myself, or every time the clock gets to 5 to the hour, we reposition, or whatever. So think about how often they need to reposition themselves. Also think about in terms of clothing for our patients as well, because obviously clothing has zips and buttons and they might be tight in certain areas and they may start to press into the skin. So think about how you can reduce the peak pressures from those items that may well be compressing the skin as well, and make sure we check those areas regularly as well. We talk about the hidden things, then the things that we kind of least expect and places we least expect to look. We really need to be thinking about looking at everywhere whereby we may think, oh, hang on a minute, is something digging in there? So look everywhere, essentially. And again, if you've got somebody that has a sling in place for manual handling purposes, can we remove the sling? If not, how are we able to negate the fact that that might well be pressing into the skin? So yeah, think about everything, essentially. So then looking at the eye in the asking for incontinence. Incontinence-associated dermatitis is often closely associated with pressure. I think that's more down to location than anything else, because we know we get the most severe damage around that kind of sacral area and around the bottom, and obviously that's where we tend to see the incontinence-associated dermatitis. But ultimately, we really should be thinking about moisture-associated skin damage and how and that and when that occurs. So think about the skin folds, looking in the skin folds, making sure that we're trying to keep the skin as clean and dry as possible. But when we're talking about incontinence, we really need to think about the extent of how long urine and feces might be sitting against the skin for. So ultimately, urine and feces are alkaline in nature and our skin is naturally acidic. So we have our protective layer known as our acid mantle that as and when urine and feces sit against it, it starts to kind of raise the pH of the skin. And therefore, we then have breakdown of that protective area. And it then exposes our stratum corneum, so the top kind of layer of the epidermis, exposes it to the effects of toxins and bacteria, and really does leave it open to skin infection. And therefore, we then get that horrible, nasty, really red, excoriated skin that's almost like a burn that's really painful for our patients. The one thing with incontinence-associated dermatitis is that when you look at it, it will be much more spread out. Pressure damage tends to be more localized, and the skin often looks quite shiny as well because of the moisture that's present. You also find that within skin folds, you'll get like the butterfly effect. So as and when you open up the skin fold, where you see redness on one side, it will basically mimic the same on the other side. So that's another indication that it would be moisture damage as opposed to pressure. In terms of protecting the skin from this, we would need to think about barrier cream. So we want to apply a barrier cream to the area, as long as the skin is intact, obviously. Apply the barrier cream. That will give that skin protection, that extra layer, essentially, so that urine and feces can't penetrate it quite so easily. And then obviously we would reapply as and when someone's had an incontinent episode and we've cleansed the skin, we reapply the barrier cream. A good continence assessment is also really advisable in terms of just trying to figure out what type of incontinence it is and how we can then reduce those incontinent episodes. So if someone's got functional incontinence, for instance, it might be the case that we think about commodes so that they can toilet themselves. And obviously toileting really is key to try and reduce those incontinent episodes. If we are thinking about product and kind of pads and things, then we need to think about making sure the pad fits correctly with the right size net pants. So hip and waist measurement to ensure you get the right size net pants, and just make sure that they are the right absorbency for your patient. So nothing too absorbent, because if it's too absorbent, it's going to take moisture from the skin if it's not absorbing urine. And that can dry the skin out. And if it's obviously not absorbent enough, then obviously it's going to leak and urine will sit against the skin that way. So looking at nutrition and hydration, so obviously we need to ensure that our patients get the right amount of calories, that they also get the good amount of protein in their diet, and that they try to maintain a healthy weight for them. So we try and do that obviously through balanced regular meals and any sort of extra snacks that they might need. But we will also be thinking about doing our must screening so that we can identify those patients who are at risk of malnutrition, and we can refer them to the right team members if we need to. So dietitians, for instance, occupational therapy, to ensure that they have the ability to be able to eat and drink and have the right balance of nutrition for them. In terms of hydration, we're looking at the standard of 8 drinks per day. That's very subjective in terms of what a drink is, because obviously you can have tiny little cups and big mugs. So if we look at it in terms of the amount of meals someone should have in 24 hours, we're looking anywhere between 2,000, 2,500 meals for an adult. That might be a little bit give and take depending on somebody's weight.
Okay, and then we'll just come to the last section of this, which is around giving information to our patients. And that's really important. So one of the aspects of there's 2 aspects to giving information. There's the information that we give you as clinicians and as healthcare professionals that allow you to understand the process of how pressure ulcers are created or happen and how to manage them. And research has shown that the more education that's put in, then the lower the incidences of pressure ulcers are, because education is key to prevention. So that's really important. But the other side of it is also that communication and education to not just our patients, but also to those who are caring and who are around our patients. So we need to really try and engage our patients as being in partnership with us as healthcare professionals, so that they understand why we're asking them to move, why we're putting them on specialist equipment, why we have to use different things with them and that, but also for their families and carers, because it's not a natural language, is it? It's not a natural language for those outside of healthcare. Talking about pressure ulcers or even knowing about pressure ulcers is not a natural language. So we need to make sure that we're communicating well. It takes 5 minutes. Even the research shows that if we give a patient an information leaflet, that on its own has not got as good effect as if we give them an information leaflet and sit down and chat to them about it. So that's really important as well. So it's about giving that information. So just coming to the end, there has been a question about what is the correct term to use. It is now pressure ulcers. So we don't use bed sores, pressure injury, pressure damage, or decubitus ulcers anymore. So the the NHS improvement guidelines from 2018 is, again, as we said earlier, about standardizing that language. So it's now pressure ulcers. So that kind of brings us really to the end of this session, doesn't it? So if you've got obviously any questions, either put them into the question answers, but also, you wanted to
Yes, so we
Anita wanted to talk to you.
So ultimately, this obviously is just a snippet of what we provide at Oscar in terms of our clinical training. We do have our training academy with many modules that you can access from pressure ulcer prevention, yes, but pressure ulcer prevention and wound care. And also we do things on skin inspection, root cause analysis, etc. So there's lots of different modules. So we do have our, hopefully you can see that, our new brochure that is out and about, which hopefully you will get access to. And if you are interested in any clinical training from Oscar, then please just indicate that on the poll that's now on your screen. And that really does bring us to the end of the session. Apart from the fact that I also do need to tell you that we then have our, obviously, we carry on with our Peers Under Pressure series in December, and our next session is on the 7th of December. So that's on keeping moving. So all of the information on that will be out shortly. So please keep your eyes peeled for that and do register for that session. But yes, thank you very much for attending today's 30-minute session. Hope you enjoyed it, that you've got some takeaways, and we shall see you soon.